Sumit, Dr. Navneet sir is joining, ma?
Yes, sir. No, yes, Naveen sir told me, sir. He will
Praveen
join.
sir is joining?
Yes, sir. He told me he will join, sir.
Okay, good. You want me to remind or you want like to remind?
So he will join, sir. He will probably join. He
Okay,
also shared the link on the group, sir.
Okay, no problem. So friends, it is close to 8 o'clock. Good evening, everyone. We have two eminent faculty who have joined together for a very important session. We have two cases. One is varicose vein to be presented by Dr. Sumit Bishnoi. Sumit is from All India Institute of Medical Sciences, Jodhpur, kindly contributed by Professor Naveen sir. And we have another candidate kindly contributed by Professor Ishwar Hosamani sir from KIMS Hubli. Is Arvind. Arvind is going to talk about a parotid carcinoma. And I thank Dr. Hitesh and other faculty who introduced to the invited faculty. Professor Sukla, I'm sorry if I'm not pronouncing your name properly, sir. Professor Sukla Vaidya is a professor and head of the department of medical college from Silchar. So he's from Assam.
Silchar Medical College, Assam, near
Yes,
Mizoram, state of
yes,
Mizoram.
Thank you.
Yeah.
And in fact, I should put on record, sir was requested only in the afternoon. In spite of Navratri observance, sir kindly accepted to stay for the class for the first class. Thank you very much, sir. We look forward for having you more for the coming up sessions, sir. So,
Surely, sir.
I would request now Dr. Sumit Bishnoi to start his presentation. We have Dr. Ishwar Hosamani also. I request sir also can participate and ask questions to the candidates. Karnakaran sir, Rajiv Sahay sir and Srinivasan sir are with us for a long time and they'll also be able to chip in. Thank you very much. And I also warmly wish candidates who are going to give the exams in the coming week. Next week, we have the National Board General Surgery exams coming up. And a few states have started exams and few states are going to start the exam. So, ladies and gentlemen, we have the presentation on. Friends, we normally allow the candidates to present till the history end. At the end of history, the professors can take back to the first slide onwards and ask questions and give your comments. So then the candidate presents the entire clinical examination without stop. Candidates also have X-ray images or other information about the operative things or FNAC. So you please can discuss those slides also and the management part and complication. We have 1 hour for each case. So we wish both the candidates all the very best. Dr. Sumit, please introduce your unit chief, your head of the department, and start your presentation. Good luck to you.
Yes. Good evening, everyone. Myself, Dr. Sumit Bishnoi, Junior Resident in Department of General Surgery at All India Institute of Medical Sciences, Jodhpur. And my head of department and I am also in his unit. My head of department is Professor Naveen Sharma. So today I am presenting a case on varicose veins. I will start my presentation, sir. A 25-year-old male resident. A 25-year-old male resident of Jodhpur who is a worker at a grocery shop presented with chief complaints of dilated tortuous swelling on inner aspect of left lower limb since past 8 years, for 8 years, pain in left lower limb for past 8 years, dilated tortuous swelling on inner aspect of right lower limb for past 2 years, pain in right lower limb for past 2 years, and skin discoloration of over both ankles for 2 years. History of presenting illness. Patient was apparently asymptomatic 8 years back when he noticed dilated tortuous swelling on the inner aspect of the left lower limb. This swelling was gradual in onset, progressive, and became more prominent on standing or walking. Swelling was associated with pain in the left leg and thigh for past 8 years, which I'm sorry, sir.
Sumit, are you okay?
Sir, actually, I'm okay, sir.
Okay,
It
please
was
start.
it was associated with pain in the left leg and thigh for past 8 years, which was dull aching type, progressive in nature, and occurs more towards the end of the day and is relieved by resting. Patient underwent surgery on left side for dilated veins in 2018. Similar is the history of the history for the right side for the past 2 years. Patient also has discoloration of both the leg around the ankle joint, which is gradual in onset, progressive in nature. No history of intermittent claudication, no history of fever, no history of any injury or trauma, no history of decreased sensation for hot and cold, no history of any abdominal pain or lump. Past history. Patient underwent surgery for left lower limb complaints 5 years back. Patient also underwent circumcision 15 years back. There is no history of diabetes mellitus, hypertension, lymphedema, or any other chronic medical illness. Personal history: patient works at grocery store and has to stand for prolonged hours. There is no history of any addiction, and bladder and bowel habits are normal. Family history: there is no history of any similar complaints in any of the family members. So my summary is: a 25-year-old male presented with complaints of dilated tortuous veins in medial aspect of left lower limb for 8 years, which is progressive and increases on prolonged standing and walking, and is associated with pain over the left lower limb for 8 years, which is dull aching and increases in severity with prolonged standing. And there is also complaint of skin pigmentation over bilateral ankles for 2 years. Patient also had similar complaints over right lower limb for 2 years.
Parotid, please take over. You go back to the first slide, Dr.
Yes, sir.
Smith. Please take over. Shukla sir.
Yeah, Dr. Smith.
Yes, sir.
Yes, sir.
Does the patient have problems with the lower limb?
Yes, sir. I'm not able to hear you properly, sir.
The patient has problems with both the lower limb.
Patient has complaint bilateral lower limb, sir. Yes, sir.
Also, left limb for past 8 years, and he's 20. What's his age?
Sir, his
25.
age is 25 years. Sir.
So at the age of 17,
Yes, sir.
he had varicose veins.
Yes, sir.
So what do you think would be the cause of such an early case of varicose veins?
Sir, because the patient.
Is it seen in such young patient?
Sahai sir, I think there is some issue with your microphone, sir. We are getting a lot of disturbance.
Others, please carry on. Others, change the volume.
I will request other faculty to ask the questions till Dr. Sahai sir sets up this audio. Professor Shukla sir, please.
Yeah.
Yes, sir.
This in continuity to his question, that is, he's trying to say that it is for 8 years. That means at the age of 17, he has started.
Yes, sir.
This swelling. So,
yes.
So the cause might be 17 years before that.
Yes.
Yes. At
The
that
patient,
time, what he was doing?
Yes.
At that time.
Yes.
At that time, 17 years before is the age of 17. What may
Yes.
be the predisposing factors for that?
So because the patient developed the complaints in very early age, so it can be if there can be a possibility that patient might be having congenital problems related to the valvular incompetence in the superficial venous system, or in or in the perforators.
Yes, you have said that he was working in the grocery shop.
Yes.
So, for since how long he was working in the grocery shop and prolonged standing and walking condition that has predisposed it.
Yes, sir.
I think in children age group he was working as a
Yes.
grocery shop. Is not it?
Yes, he started early doing this type of work, sir.
Okay. Okay. So it took around 5 years back he was being operated. No.
Yes, sir. He was
In
operated
the
in a
lab.
private. Yes, sir, in a private hospital. Yes.
But no relief was there, or was there any relief to that?
He said that
You have
he said that he did not get proper relief, sir. The swelling did not reduce in size, sir.
Okay. Okay, then again 2 years back. Yeah.
So please.
Again 2 years back he started again in the right side.
Yes, yes, sir. He also
So,
started having complaints over the right side.
right side. In these cases, he's a male.
Yes.
He's a male. Yeah, this bilateral involvement by
Yes.
varicose vein, what may be the probable in the history side, what may go to the probable thinking about the cause of this?
Sir, because his age is less and he in his early in his life he has developed these complaints, and so there might be some predisposing factor related to some congenital defect in the superficial venous system, and this also got aggravated with the predisposing factor because of prolonged standing. So there is a possibility that patient might be a uh, not patient might be a case of congenital causes of some vulvar incompetence, which
No,
has not
Sumit,
been.
hang on.
Okay,
Sumit,
okay. Please carry on.
Sumit,
Next.
Sumit,
Yes,
Sumit,
yes, sir.
Yeah.
Yes, sir.
can you tell me
Yes.
a cause of congenital varicosities?
Sir, the most commonly, sir, usually we say clipal Trenaunay syndrome, sir.
Yes. So what happens there?
Clipal Trenaunay syndrome.
What is KTS syndrome? What
Um,
happens here?
Sir, in this syndrome, usually, sir, there is vulvar incompetence along with swelling in the lower limbs, sir.
No, it's basically involving the development of certain blood vessels and lymphatics,
Yes.
right? With soft
Yes,
tissue and bone involvement, right? So it's not because of valvular. Valvular abscess is very rare. Okay, so he underwent surgery for it about 5 years back.
Yes.
So why do you think he didn't get relief? Why has it come back again? And there's a swelling in the limb.
Yes. Sir, probably because the surgeon who operated, he might have left some of the tributaries of some of the.
No. Why do you think? Come on, don't think the surgeon is incompetent. There could be other causes. We expected the surgeon to be doing a good job.
There might be neovascularization, sir, and there might be some of the perforators.
More important would be some form of deep vein thrombosis.
Yes, sir.
Some form of deep vein thrombosis which has happened over the years.
Yes.
Right. Okay.
Yes,
let's go to the next slide, please.
Yes.
8 years back, he noticed dilated tortuous vein on the inner aspect. Okay, what is how do you define a varicose vein?
He started having pain.
No.
At that time.
What is the literal definition of varicose veins?
Varicose. Yeah.
Sir, in the literal definition, we say that any dilated vein that is more than 3 mm in size, sir.
It is dilated, tortuous, elongated veins,
yes,
more than 4 millimeters in size. Superficial, which is more than 4 millimeters in size. Okay.
Yes.
So the swelling was gradual in onset, progressive, and becomes more prominent on standing and walking.
Yes.
Okay. So why do you think this is happening? This swelling becomes The swelling becomes, which swelling becomes? The limb swelling.
Yes, sir, the limb swelling.
Huh?
Swelling over the medial aspect of the limb, sir.
No, the varicosities
venous
become more
dilatation.
prominent.
Venous
varicosities-
dilatation, sir.
Yeah,
Varicosities,
so
sir.
you just say that the varicosities become more prominent on
Okay.
standing or walking.
Okay, sir.
So what does that tell you? Suppose
Uh,
a varicose vein is becoming more prominent on standing and walking.
Yes,
What
sir.
does it tell you? What is the involvement?
So it suggests that there is venous stasis in the lower limb, sir.
Fine. Okay. Okay. But
And
okay. Why do varicose veins happen?
so varicose veins usually happen because there is the usually the calf the muscles in the calf usually act as pumps for flowing in the proper flow of blood through the superficial veins. But
Right.
when there is some defect in that, or some there then and their patient is having prolonged standing, and
No,
there
no,
is lot.
Sumit. Simply put, there is reversal of flow. Normal flow gets reversed because of
Yes,
any reason.
yes,
Flow is from the superficial to deep. Now the flow becomes reversed.
yes, sir.
So that's simply put, that there is reversal of flow.
Reversal.
So it can come from above downwards, from below upwards.
Yes, sir.
So while walking and standing, means that either the saphenofemoral is gone,
Yes, sir.
and while walking, there's reversal of flow from the perforators. So probably both is gone. That's what it tells you. The history tells you very clearly.
Yes, sir. There is
Okay.
reversal.
Next slide. Similar history on right side for past years. There's no complaint on for past 2 years for the right side.
Yes, sir. There is a complaint since past 2 years, sir, over the right side.
So which is more severe, the left or the right?
Sir, currently he was more severe on the left side, sir.
Actually, by your history now, we're not clear whether the patient has presented with both the limbs or just the left limb. The
So
complaints,
patient has complaint in both the limbs, sir, and
right?
he has
The
pain
left
in.
limb is more than the right.
Yes, sir.
The left limb.
Pain is more in the left limb.
So there is pain on the right also.
Yes, sir. There is pain right
And
also.
any varicosities on the right? Does he complain of
Yes, sir.
varicosities?
There are varicosities also in the right.
Okay, next slide, please. So it's on both the ankles. Now, what does this mean? Discoloration of both the legs around the ankle. What does it mean?
Sir, this sir, this might suggest that there is skin pigmentation in the ankle region, sir.
So when does skin pigmentation happen? Why does it happen?
Sir, because of the stresses of blood, this hemoglobin gets collected in the subcutaneous tissues and get broken down.
The RBC, they move out.
RBCs get move out and get broken down and give the color to the skin, sir.
Okay. So what is chronic venous insufficiency then?
So chronic venous insufficiency is a broad term to suggest that the causes which can lead to varicose veins, sir. And it usually suggests that there is stresses of blood in lower limb, and which can lead to varicose veins and other similar complaints because of the prolonged stresses.
So this is one of the manifestations of a chronic venous insufficiency.
Yes,
Right?
yes.
Okay, no history of intermittent. Look, now in your history,
Yes,
any limb vascular swelling, you must rule out whether it is arterial or venous.
Yes.
So arterial, just by IC, intermittent claudication is not sufficient.
Okay.
You must take other histories also of arterial
Arterial.
What are they?
Sir, in arterial insufficiency, the pain is usually more severe, and the pain gets relieved when the patient keeps his limb in the lower, and in the venous.
Okay, there is, when he rests, the pain decreases.
Decreases.
The pain appears on walking, right?
Yes.
Because the pain will, in venous, the pain will appear more towards the end of the day and is
Yes,
relieved by Elevating the limb.
elevating the limb, sir.
Okay.
Yes.
And the other features also. Okay. No history of fever. Why do you take the history of fever?
Sir, because patient has developed swelling, and there might be some patient might have developed some collection in the lower limb that
Okay. What are the
collection.
features of deep vein thrombosis? How does the patient of deep vein thrombosis present?
Sir, in patients of deep vein thrombosis, there is dilatation of the superficial venous system also, because the deep venous system is
No. Sumit, I'm just
yes,
asking you, how does the patient of deep vein thrombosis present?
pain, sir, pain,
They present with pain and
swelling, pain and swelling.
swelling of the limb,
Sir,
and
pain,
there can be fever also, right?
yes, sir, they can
There
be
can be
fever.
fever. So this is there. So this is your thing should be that whether you have to rule out by your history whether the patient has a DVT or not.
Yes, sir.
So your whole history and examination depends on three things.
Yes, sir.
One, it's the venous system, whether the deep vein is involved or not,
Yes,
and
sir.
whether the valves are involved or not. These are the
Yes.
three things which you have to, in varicose veins, you have to find out by your history and examination, these three things.
Okay.
Right? So
Yes,
this
sir.
is how you have to do.
Yes, sir. Hello.
Yes,
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 as you have told, this intermittent claudication, just I'm coming to that. It's we get in the peripheral vascular diseases like arterial and venous claudications, and also another claudication of nerve origin.
yes,
So this characterizing of this are different in different conditions, is not it?
yes,
So in this, because of this the varicosities, the long saphenous or great saphenous vein, what we say, that are having some valves which become incompetent, is
yes,
not it?
yes, sir.
Because this gravitational force normally when it is it remains functional, it is
Yes.
not giving, but gradually what happens to that, the valves? Because etiologically we can divide this varicose veins into the primary, secondary, and congenital type. Congenital varieties are there.
Yes,
So whether in this case group we should think about whether this is a of primary cause of varicosities.
yes,
Yeah. And regarding this, you have told that abdominal pain and lump. What do you think about the abdominal pain and lump?
sir, I took this history because there might be causes when there might be compression in the of the venous system because of a large abdominal lump, and which can lead to venous stasis, and can lead
Example?
to, sir,
Example?
some pelvic masses in malignancies or
Pelvic masses. And it
in
is said that in some physiological condition, like in pregnancy also, is not it?
pregnancy. Yes,
So, as it is a case, male case, so that question doesn't arise.
yes,
But repeated pregnancy also, some other causes there. So that's all.
yes.
Can we move to next slide, please?
Yes.
Yeah. Uh, so regarding personal history, what do you think? What personal history that can predispose to any dietary habits or anything related to this?
Sir, there have some studies that say that because of smoking, there is patients are more predisposed to this varicose veins. So addiction history is important, and also because of the occupation, if a person is standing for long hours. So
Long hours, like your conductor, bus or
bus,
conductor and all. Then those who are doing prolonged, even many of the surgeons are having also varicose veins. Surgeons are having varicose because prolonged standing, long time of operation and all these things. Is not it? And does this your obesity may predispose to this? Those obesity?
So yes, sir, obesity can also predispose, but I'm not sure.
Okay, regarding the family history, what you have told, that what about that family history?
Sir, in congenital causes, there might be some family history of varicosity, similar complaints.
Okay, then we can go ahead, sir.
No, I'd just like to ask you, Smith. Like
Yes.
Yeah,
you
yeah,
said,
please.
there's primary and there's secondary,
Yes,
isn't it?
yes.
So, do you think this is a primary varicosities? What are the points in favor and what are the points against?
Sir, primary varicosities are, we say when we usually don't get any other cause for the development of varicose veins. And secondaries are usually caused due to some predisposing factor like DVT.
That is the general term for primary history.
Yes.
In primary varicose veins, what is the difference? How is it different from secondary varicose?
Sir, primary varicose veins usually develop early in the life, and
One,
secondary,
early adolescence.
yes, in
Second,
adults,
Yes.
and in primary, we cannot definitely say the why the patient has developed varicosities.
don't keep harping on the same point that we can't see.
Yes, sir.
What are the other difference? There's a positive family history in primary.
So there is no usually no family history in primary varicosities.
Oh, there is a family history in family history in primary, right? Third is there will be no dermatitis in primary.
Okay, sir. Okay, sir.
And there'll be it will be generally the deep veins will be normal, everything will be normal.
Yes.
Except that the patient will have
dilated
varicosity.
veins. Yes, sir.
While in secondary, it is in elderly group, old age, deep veins may be involved,
Yes,
right?
yes.
And there'll be skin changes.
Skin changes, yes. Chronic skin changes.
So should we go? Right, sir.
Yeah, it is superficial system of vein is more involved in the primary than the deep venous system.
Yes.
Yeah. We can go to the next slide, I think.
Yes, please.
Yeah.
Should we go to the examination, sir?
Yes, we can go to the examination part. Yeah.
Yes. So general examination. Patient was examined after proper consent in a well-lit room. Patient is conscious, oriented to time, place, and person. Patient is thin built. His vitals were normal. His weight was 58 kgs. Height was 162 centimeters. BMI was 22.1. Patient had no complaint of pallor, icterus, clubbing, lymphadenopathy. There was no pedal edema or sinuses. So this is the image of the patient. Sir. Patient has complained in bilateral lower limb. So local examination on inspection on left side, there is a 4 centimeter scar mark along left. There is a 4 centimeter scar mark over the left thigh, 3 centimeter below inguinal ligament, and 5 centimeter lateral to left pubic tubercle. And there are multiple small scar marks less than 2 centimeter in size over anterior aspect of left leg. There is dark skin pigmentation over medial aspect of left thigh extending up to left lower leg. There are dilated tortuous varicose veins present over anteromedial aspect of left lower thigh and left leg. Over the right side, there is dark skin pigmentation over medial aspect of right angle extending up to right lower leg. And there are dilated tortuous varicose veins present over anteromedial aspect of right lower thigh and right leg. There is no limb deformity. There is no ulceration, no muscle atrophy or hypertrophy. There are no signs of gangrenous changes or arterial insufficiency. On palpation, over the left side, there is no raised local temperature, no tenderness, no pedal edema. All peripheral pulses were palpable. The Brody's standalone work on doing Brody's standalone work test On keeping the tourniquet and making the patient stand, there is filling of GSV from below, which suggests positive test, which suggests that there are incompetent perforators in the left lower limb. And on removing the tourniquet, there is no sudden filling of GSV from above, from SFJ, which suggests that there is no SFJ incompetence, and which suggests the test is negative. And on doing multiple tourniquet test, there are multiple incompetent perforators over lower thigh, left lower thigh, left leg, and over the ankle region. On doing modified Perthes test, it was negative, which suggests that there is no evidence of DVT. And Schwartz test was also negative. On the right side, there is no raised local temperature, no tenderness, no pedal edema. All peripheral pulses were palpable. Brody's Tendelberg test was on keeping the tourniquet. There is filling of GSV from below, which suggests test to be positive. On removing tourniquet, there is sudden filling of GSV from above, which suggests that the SFJ is incompetent. And on doing multiple tourniquet test, there were multiple incompetent perforators over the right lower thigh, right leg, and over the ankle region. And on doing modified Perthes test, it was negative. There is so which suggests that there was no evidence of DVT. And Schwartz test was positive, which on doing palpation over the on doing the palpation in the course of the lower vein in the lower limb, there is impulse is felt at SFJ, so which suggests that the test is positive, and there is SFJ incompetence. On percussion, thrill is palpable over right SFJ on tapping over the dilated vein. Auscultation, no bruit is heard. So on systemic examination, abdomen is soft, non-tender. There is no organomegaly. And on CVS examination was normal. Respiratory system examination was also normal. And CNS examination, there is no sign of neurological deficit or motor weakness. So the summary is a 25-year-old male presented with a complaint of dilated tortuous veins in the medial aspect of left lower limb for 8 years, which is progressive and increases on prolonged standing and walking, associated with pain over left lower limb for 8 years, which is dull aching and increases in severity with prolonged standing, and skin pigmentation over the left ankle for 2 years. Patient also had similar complaints over the right lower limb for 2 years. On examination, varicosities involving bilateral great saphenous veins with right SFJ incompetence and multiple varicosities over bilateral thigh, leg, and ankle with no evidence of deep venous thrombosis. And my diagnosis on the basis of history and examination is bilateral lower limb varicose veins involving GSV and with multiple incompetent perforators over the entire course of GSV. And the C classification is C4 ERP ASP ER.
Okay.
Sumit, can you?
Yes.
Sumit, can you tell what do you understand a Brody Tendelberg test?
Sir, in Brody's Tendelberg test, we first usually empty the veins by asking the patient to lie supine, and we lift the leg above the level of the heart, and the superficial veins are emptied. Then a tourniquet is tied just below the SFJ opening, and we ask the patient to stand. And then first, before removing the tourniquet, if there is filling of veins from below, filling of superficial venous system from below, which it suggests that there are incompetent perforators over the course of the vein. And if there is no filling, and after removing the tourniquet, there is filling from above, which suggests that there is SFJ incompetence.
Okay, so in your case, on bilateral, it was positive.
No, sir. On left side, it was not positive, sir. On right side, it was positive.
Okay. And did you do
Sir,
the multiple tourniquet test?
yes, sir. I did, sir.
Okay, what did that show?
Sir, it showed that there are varicosities over at multiple levels. It was in the also in the lower thigh and over the leg and also at the ankles.
How many tourniquet you applied?
Sir, I applied 5 tourniquets.
Okay. And how did you open those tourniquet?
Sir, I opened the tourniquet from below upwards.
From below up. Good. And did you check for the Fegan test?
Sir, Fegan test I tried, sir. At some places I could feel the opening, but not properly, sir.
Yes. Why do you find opening? What is that opening?
Sir, these are the sites where the perforators perforators enter from the superficial to the deep venous system, sir. So there is a defect in the fascia at that site, sir. So that defect
Yes,
is found.
that defect is that defect S-shape, some semilunar defect, is not it?
Yes, yes, sir.
Just coming to this sir's question, that it is very much evident that left side you are not getting Rendelberg test. This that is positive and negative, is not
Yes,
it?
sir.
And
Yes, sir.
right side both positive and positive, is not it?
Yes.
What is why is the difference?
Sir, probably because patient was operated over the left side, sir, because there was a
Left
scar over the left inguinal region. So probably the
Yeah.
patient got operated, and there might be like they ligated the GSV at the junction, sir, flush ligation.
So earlier that was a probably you can say it is a successful or unsuccessful ligation.
Sir, ligation was successful, but patient because of the perforator, patient had persistent complaints, sir.
Yes, perforator, this perforation continued, but that part was very well done procedure. So now you are having in the right side both saphenoperitoneal incompetence as well as perforator incompetence, is not it?
Yes.
So you see, if normally if we do this broadening Teddy-Bears test in the normal patient,
yes,
what do you think that after tourniquet, this tourniquet test,
yes.
what will be the feeling of the veins?
Sir, I do not understand the question.
From lower limb side. From this tourniquet from the lower limb side, normally,
Yes, sir.
what should be the feeling? There should be a normal feeling and there should be a rapid feeling.
Yes,
If there is a rapid feeling, we can say it is positive, is not it?
yes.
Yes. So, sir has asked you about the different tourniquet test. Why this different tourniquet test you are doing?
Sir,
What?
sir, when we do the produced and blood test, sir, in which we only use single tourniquet, sir, and we do also multiple tourniquet tests to look for the exact site of perforator.
Exact site. So how many perforators are there in the legs?
Sir,
how many perforators are?
So there are 5 groups of perforators, sir, over the entire course of GSV, sir. Hunterian perforators, Doyd, Boyd, Cockett, May, and May or Custom.
From below upwards or below
from
upwards
from upwards to below, sir. Hunterians are in the mostly in the mid thigh. Doyd perforators are in the lower thigh. Boyds are in upper leg. Cockets are in mid leg, and May or Customers are near the ankles.
In the exactly ankle. Is there any perforator with the short saphenous vein?
Yes, sir, there are in short system also, sir. There are perforators.
Perforators are there. Just sural perforators or like that. Yes.
Okay.
Where are these perforators situated in the long saphenous vein?
Yeah.
These perforators are situated on the long saphenous vein, or they are situated somewhere else?
Sir, these are usually in the course of large veins, sir. Deep veins.
No.
Okay, which
question
vein
is something else.
Which vein to which vein is joined?
Yes.
You have the superficial.
These join the great saphenous vein to the.
think there's some disturbance there.
డేట్ పడిపోతుంది
Some disturbance is going on. Yeah.
లోపల స్టాంప్ ఉంటుంది కదా ఆఫీస్ కి ఆ ప్రిన్సిపాల్ రూమ్ లో అక్కడ ఉంటుంది ఆ సీల్ వేయించారు ఉంటారులేండి అటెండర్ ఒక
Hello, could you
Yes.
please
Hello.
mute yourself? Okay,
Mm.
okay, Sumit, you
Yes.
have the long saphenous vein. You have which are the deep veins in the leg?
Sir, in leg, the deep ones are anterior tibial vein, posterior tibial vein, and which form the common peroneal veins, and
So you have the three veins. You have the common, you have the peroneal, anterior tibial, and posterior tibial. So
Yes.
most of these perforators open into which deep vein?
Sir, posterior tibial veins.
Okay. Now, what are the types of perforators?
I mean, these perforators, they are on the superficial system, you know.
Yes.
Okay.
So
And
what
they are not on the long saphenous vein, but it's a branch of the long saphenous vein which is
It's
there,
called?
posterior arch vein.
Arch vein, exactly.
Posterior arch vein, you know. So
Arch vein
these
of
vein
Leonardo.
perforators which are there, they are along the posterior arch vein and not on the main saphenous vein.
Okay. So what are the type of perforators which are seen there?
Types
You have the
of,
direct perforators and indirect perforators. What are direct perforators?
Yeah.
What are indirect perforators?
I don't know exactly.
Okay, so direct perforators open directly into the deep vein. Indirect perforators, they open into a sinus.
Okay.
Okay. So ask you about Fagan's test.
Yes.
Why do you think you can palpate a defect in the superficial fascia? Normally, also the perforator is going. You should be able to palpate it. Why does it happen only in varicose veins?
So because of the
Normally, also the veins, the perforators will perforate through the deep fascia, the
Yes.
superficial fascia, and enter the deep
Yeah.
vein.
yes. Sir.
So you should be able to palpate the opening there also. Normally,
Sir,
why don't you do it?
Usually because of the dilatation in varicosity.
Right,
varicose
very
veins.
good. So because of the reflux, the opening gets enlarged,
Yes.
and then you can palpate it. Okay,
Yes.
just go back to your examination.
Yes.
Sumit, you have to examine in a peripheral vascular disease. You must examine the arterial system.
Yes.
Have you examined all the pulses?
Yes, sir. I examined the pulses in the lower limb, sir. Up to the
I
anterior
didn't
tibial,
see
posterior
them.
tibial.
I didn't see them. Maybe I missed it.
So, actually, I told in palpation, I told that all peripheral pulses are palpable.
No. Hang on. You can't say that. You have to do it. You have to tell me the gait, the limb girth, the presence of hair in the integumentary system. All that has to come there. You get me?
Yes. Yes.
So please.
Yes.
Sumit, when you say in the Brody-Tenenberg test, it
Yes.
is not only the rapid filling which makes it positive, it is the reversal of the flow is there.
Yes.
Okay, so that is very important. So rapid filling plus reversal of the flow
Yes.
has to be there. So the flow will be from up down. Normally it fills from below up.
Below.
In the case of the incompetence, it will be filling up down.
Up,
Rapid
down.
filling plus reverse filling there. Okay.
Okay, Sumit, I just wanted to tell you, like I said, you in a case of varicose veins, you have Trendelenburg 1, which is
Yes.
for the
Sir,
septal, right?
Yes. Sir.
You have the Perthes for the deep vein thrombosis.
Yes.
And you have the multiple tunicate Trendelenburg 2 and all that stuff to find out the
Yes.
perforate. So
Yes.
these are the three tests, and you must know the basis of each of the three tests. What is the basis of Perthes test?
Sir, in Perthes test, if a patient in this case, usually we tie a tourniquet at the level of just below the SFJ opening, and we ask the patient to walk. So if there is deep venous thrombosis, then there is patient will complain of pain in lower limbs, so increased pain in lower limbs.
Why will he complain of pain?
Sir, because the deep venous system is obstructed. So the venous flow will be through the superficial system. and which will cause the pain, sir. There is stresses and there is pain, sir.
So the flow through venous superficial venous system is painful.
Because of such stresses.
Yeah, because there's insufficient flow, outward flow.
Yes, sir.
So there's stasis, right?
Yes.
That's why you get pain. What is Trendelenburg 1?
So Trendelenburg 1 is when there is before removing the tourniquet, there is if there is filling of the superficial system from.
So you empty the vein.
Yes, sir.
You occlude the
SFJ.
SFJ and ask the
Yes.
patient to stand,
Yes.
right?
Yes.
Now, if the FSJ is competent, what happens?
If it is competent, then sir, there is no before removing the tourniquet, sir, or after removing? Sir?
Yeah, before removing. You have asked the patient to stand
Yes, sir.
with a tourniquet in place,
Sir, there is then there is no filling of the superficial system, sir.
or there may be slow filling, reverse
Slow.
filling if the perforators are incompetent. Right?
Yes. Yes.
And on removal it, there's a rapid filling from above downwards.
Yes.
Right? Okay. All other tests are just adjunct. These are the 3 most important tests which you have to do.
Yes.
So please, sir.
Sumit, what is the normal pressure of the veins at the ankle? Venous pressure? When you're standing, how much is the pressure in the veins at the level of the ankle?
So it is usually around 5 to 10 millimeters mercury more than the level at the level of the heart, sir.
Oh, no, it is almost equal to the arterial pressure. Okay, it is around 80 to 100 millimeters of mercury at the ankle if you are standing. But once you start walking, what is called the ambulatory venous pressure,
Yes.
then this pressure falls to around 20 to 25.
Yes.
And in fact, if you look at a person who has got a normal limb or a
Yes.
person who has got the varicose veins, the resting pressure will be the same, 80 to 100 in both. But the ambulatory venous pressure will be lower in the case of the normal, while it will be case higher in the case of the patients having the varicose veins.
Yes.
So if you measure a patient who has got the venous ulcer, C5, C6 disease is there,
Yes.
there the ambulatory venous pressure will be around 70, 80.
Yes.
Okay. So it is the ambulatory venous pressure which makes a difference. You know? Now, somebody was asking about why this is recurrence of the veins are there. What are the cause for that? What are the various causes for recurrence of the varicose veins?
So recurrence can be due to neovascularization because of formation of new collaterals that lead to
Yes.
recurrence.
Anything else apart from the neovascularization?
Because initially there might be perforators that were competent, but because of prolonged stresses, or other causes, perforators have become incompetent later, so that can cause recurrence.
Okay, it can be because of neovascularization.
Yes.
Varicose vein is a progressive disease,
Yes.
so the other veins may be involved. Then you are missing the veins, like you have done a surgery for the main GSP, but many times you get what is called the accessory veins which are there. Anti-accessory vein is there, Giacometti vein is there. If
Yes.
you are missing all those veins which are there,
Yes.
then there is a chance of the recurrence.
Recurrence.
So these are the various causes for the recurrence of the varicose veins. Right.
Yes, one recurrence when this Trendelenburg, this operation that is being just flash ligation was not successful also. There,
Yes.
this recurrence may occur also from that.
Yes.
Yeah.
Now, can you
flash
go to
ligation.
a diagnosis where you have written the SEEP classification?
Yeah.
So
Yes.
what is C4?
Sir, C4 is sir, skin pigmentation, sir. C4. Skin pigmentation, sir.
No, there are how many
C4
C4s are there?
Sir, usually there are two, sir, C4A and C4B. And
No,
this
there is
is
C also, you know? C4C is also there.
Okay.
Have you gone through the recent classification, the C classification, which is there? 2020 classification?
No, sir, I didn't.
Yeah. Okay, the C which was given before, there were only two C4 were there, but now there is third C4, C is there, and that is a corona phlebitica,
Phlebitic one. Yes.
ankle flare, which is there. Okay.
Yes.
So which was initially in the C1 has come to now the C4C now, because it has been seen if somebody has got the ankle flare is there, there's a very high chance of having the ulceration there. Okay. What are the other differences? You know, what are the other differences which has been made in the 2020? Have you gone through the 2020 class?
No, sir.
No, you're not. Okay. So there are few other changes which are there from the older classification.
Yes.
One is the recurrence has been added, which was not there in the original C which was there. So the recurrence has been added in that.
Yes.
So recurrence at the level of C2 also, and recurrence also at the level of C5 also. That there is a recurrent ulceration.
Yes.
Okay. Then in the E, they have added the extra venous causes for that, which were not there, like May-Thurner syndrome, which is there, which has been added in that it should be specified separately here. Apart from the C4C, which is there. So these are a few differences which has come in the recent classification of the CPI. Should you do a ABPI in these patients or not?
So
In case of varicose veins, whether we should do the ABPI or not?
Sir, the role of ABPI is when we give treatment for varicosities, we give graduated compression. So if the patient is having arterial insufficiency and there is decreased flow in the lower limb, and we advise the patient for higher pressures of stockings, then the patient will have increased severity of the arterial insufficiency. So in that cases,
so if the arterial disease is there, then in that case you cannot give a very high compression.
Compression, yes.
Okay, high compression cannot be given in those cases. So you have to either give no compression or low compression.
Low compression.
Okay. What are the various compression grades which can be given to the varicose?
Sir, there are usually 3 grades. Sir. So
yes.
One is around 15 to 18 millimeters of mercury, grade 1. Second is around 18 to 25, and for more than 25, then it is grade 3.
And what is grade 4? Grade 4 is given in which case? If it's a lymphedema is there, okay. If the patient has a lymphedema is there, then in those cases you can give the pressure around 40. 40. So just to remember, you can say 10, 20, 30, 40, okay. 10 the grade 1, 20 the grade 2, 30 the grade 3, and the 40 the grade 4. You can remember like that also. Okay, so how you are going to investigate, work up your patient?
Sir, for workup, we will get the patient for duplex cancer. Okay.
What is the duplex scan? What do you understand by that?
Sir, it is sir, basically radiographic, sonographic workup for the venous system.
But what is duplex? What do you understand by duplex?
In this, we also look for the anatomical changes, and also we look for the flow of blood in the venous system.
So you combine the B mode ultrasound.
Yes.
Plus
B mode.
You have the Doppler in that. So it's a duplex. Two things are there. So one is for the anatomy and another is for the physiology. Okay. So when you say the saphenofemoral is incompetent,
yes.
When you say that?
We say that when there is a reversal of flow in the through the SFJ, and
how much reversal should be there to say it is the incompetent?
So it is around more than 500 milliseconds.
500 milliseconds,
yes.
Yes. And when you say the perforator is incompetent? Okay, some people say it is 350. Some people say it is the 500, which is there. Plus, there has to be a defect in the D fascia of 3.5. That's what Dr. Rajesh is asking you, that why do you feel that defect? There's a dilatation of the D fascia is there because of So you should also demonstrate that. So anatomically also, as well as the physiologically, it should be more than 350 milliseconds and a diameter of 3.5 should be there to say it is an incompetent perforator is there. Okay. Now, in the case of the Doppler duplex scan, when you are doing, what one thing you want to see really? You have to
Sir,
ask that just you have to see one thing, what you will
yes,
see.
we usually see that it is color Doppler, sir. So there is the flow is
No, I'm asking the duplex scan.
yes, sir.
If I say you just look for one thing in this patient, what one thing you will look?
Sir, the direction of flow.
No.
Mm,
You look for the deep vein thrombosis. Okay, because
Yes.
your whole treatment will depend upon that.
Yes, sir.
Okay, if the patient has the deep vein thrombosis, it's the secondary type of the varicose veins are there. The
Yes.
treatment is totally different than the primary varicose
Primary.
veins which are there. Okay.
Yes.
Then what other investigations can be done for the varicose veins? This is the main investigation. What
Yes,
others
sir.
can be done?
Sir, MR venography, sir, can be done, sir. MR venography.
You know, one of the causes of the recurrence of the vein which is there, what we are told,
Yes, sir.
something in the deep veins. Okay,
Mm.
the deep veins are incompetent. You have treated the superficial vein,
Yes,
but the deep veins are incompetent, then that will also lead to the recurrence of the veins. So
yes,
apart from what we discussed about the recurrence of veins, one of very important cause is the deep vein recurrence, is the incompetence is there.
yes.
And to see for the deep vein incompetence, what you have to do?
Sir, for
Various type of venography can be done.
venography. Yes.
You can do the MR venography, you
MR
can do the
venography.
CT venography, you can do the invasive venography, ascending venography, descending venography. What is IVUS?
Sir, intravascular ultrasound.
Intravascular. So if the patient has got the deep veins problem, you can also do the intravascular ultrasound for that. Okay.
Okay, Sumit,
Yes.
like Sir said, the recurrence is because of if there is chronic venous insufficiency of the deep vein,
Yes.
or you don't do surgery when there is deep vein thrombosis.
Deep vein thrombosis. Yes.
Right. So this is where I had asked you about chronic venous insufficiency. What happens is that the deep vein thrombosis, they get recanalized.
Yes.
And the valves become incompetent. So there's a whole pressure there, and
Yes.
that leads to venous insufficiency.
Insufficient. Yes.
The chronic venous insufficiency is because when the deep veins become incompetent.
In-
That is one of the causes for recurrence of
Varicose.
varicose surgery.
Yes.
Okay, what is May-Thurner syndrome? So I asked you about that.
Sir, May-Thurner syndrome is because of the external compression of the common iliac vein, right? This left common iliac vein from this right common iliac artery.
Why does that happen?
Because the crossing of the bifurcation of the aorta is below the level of the bifurcation of veins, sir.
No,
And
the
aortal-
left-sided veins. Sorry, Sumit, the left-sided veins have to reach the right-sided IVC.
Yes, sir.
So they move below the
Below the right common
artery,
iliac artery.
right common
Yes.
iliac artery.
Iliac.
Okay.
Yes, sir.
Okay, now this patient has got problems on both the limbs. The
Yes.
the left limb is recurrent,
Yes.
and the right limb is prime, has never been operated.
Yes.
So what are you going to do now?
So for this patient, sir, because there are multiple perforators in the left lower limb, so we can
Which one are you going to operate first? The right or the left?
So patient has more complaints in the left side, sir. So I'll operate with the left side first.
Is it because of complaint or is it because of any other thing? What are the factors which make you decide which side to be operated?
So one is patient complaint, other
The
is
complaint is fine. There's
yes,
hardly
and-
any difference. Both sides you'll have pain.
yes,
A few
recurrence.
degree here and there will not matter.
So recurrence.
No, the chances where there's going to be a varicose ulcer with the
Okay,
skin
yes.
can break down,
Yes,
right? That side has to be operated first.
yes.
Right. So what's the difference between a venous ulcer and a varicose ulcer?
Varicose.
Sorry, varicose ulcer is usually when the cause is the superficial system, dilatation of superficial venous system, and a venous ulcer can be because of any other cause related to the venous system, like deep venous
So just
thrombosis.
give me the answer. Don't just rephrase my question.
Sir, I don't know exactly, sir.
Yeah. So say that.
Yes,
Right? Like varicose is a superficial ulcer.
yes, sir.
Venous ulcer will be a deep ulcer.
Deep ulcer. Yes.
Right? Where does varicose ulcers happen?
Sir, usually at the site of ankle, sir.
On the medial side.
Medial side of the ankle, sir. Medial side
Why
of
does that happen on the medial side?
Sir, that happens usually because there are in more perforators at that side, sir.
Because the whole venous system, superficial venous system, is on the medial side,
Yes, yes, sir.
isn't it?
Yes, sir.
So what is Linton's line? Have you heard of this term? Linton's line.
No, sir. Link.
Right. So this is the area 3 centimeters around the medial aspect of the leg,
Yes, sir.
where all the perforators and the ulcers happen.
Okay.
So when the patient is standing up, all
Yes.
the pressure is on the ankle, on the medial side. So that's where the ulcers happen. That is known as what area? What is that area known as?
Gator sacrum, sir.
Yeah. So you have a venous ulcer, varicose ulcer, which is superficial. You have history of varicosities in there, and
Yes.
usually they don't have pedal edema.
Yes, sir.
Pedal edema is a feature of chronic venous insufficiency of venous ulcers,
Venous ulcer. Okay, sir.
and because they're superficial, they'll be superficial to the superficial fascia. Venous ulcers are deep to the superficial fascia,
Deep to the superficial.
and their venous ulcers are very difficult to treat. Varicose
Yes.
ulcers are easy to treat.
Easy to.
Okay, so you said, sir asked you about Doppler. You
Yes.
said anatomy and flow. So what we look
Yes.
for in the anatomy of the vein?
Sir, in anatomy, we can look for the walls, sir. There is
Can you see the walls?
reversal of the flow through the walls, sir.
That is in flow.
Yes, sir.
Anatomy,
And
yes.
also the size of the veins, sir, the dilated, how much veins are dilated, sir.
Okay, you see the size. Does that help you? Doesn't. Most important in anatomy is that you see whether there's a thrombus or not.
Okay.
In anatomy, you'll see whether there's a thrombus in the lumen or not,
Yes.
whether there is any flow through the thrombus or not, whether thrombus is floating it completely or incompletely.
Incomplete. Yes.
Right? In flow, you see all those reversal and by compression or by or other
Half
methods.
compression. Yes.
Right. Okay. Now, how will you proceed in this patient? Have you got his Doppler?
Yes, sir. We got the Doppler, sir.
Can you show it to us?
Sir, I haven't included this slide, and it was on.
Do you remember?
Yes, sir. Actually, in the Doppler, they said that there is bilateral GSV incompetence in the report, and there are multiple perforators in the entire course of the GSV in bilateral organs. But they also said, yes, sir, but they said that the bilateral GSVs are incompetent. But in my findings, sir, I could not find that.
No, bilateral great saphenous vein involved?
The bilateral SFJ incompetence, sorry. Bilateral SFJ incompetence.
SFJ involved. Okay. So now what will you do? Can you open both the limbs together?
So we usually don't prefer to open
Why
both
don't
limbs.
you? Why don't you?
So because patient will have increased pain and in postoperatively, and patient.
Why in one side if you operate, the other side both, you can manage the pain equally on both sides. Same painkillers.
But if patient develops any postoperative complication, then
right. So first of all, you make him immobile. Then you have complications all the time. Okay, what will you do? What surgery will you do now?
Sir, for the left side, we will do, sir, perforator ligation, sir, for the left lower limb.
Just perforator ligation.
Yes, a perforator ligation, and we will also we can also do, sir, tendon work procedure also, sir.
What do you mean with Trendelenburg procedure?
Sir, it means that we will flush ligate the SFJ junction, and we
Okay.
will also
So how do you identify the SFJ?
Sir, SFJ is usually present around 4 centimeter lateral and below the pubic tubercle. Sir.
Okay.
Yes, sir.
What is that? What is that opening called?
This opening. So it is the in the opening of the cribriform fascia. Sir.
The cribriform fascia covers. It's called the saphenous opening, isn't it?
Yes.
The cribriform fascia covers it. So what is this defect in? What is the structure through which?
Fascia, sir. Deep fascia. Sir.
What is the name of the fascia?
Fascia lata. Fascia lata.
Right, it's fascia lata. Okay, so you said that there can be, you can have missed,
yes.
This person could have missed some of the vein, the tributaries. What are the tributaries seen at the SFJ?
So usually there are 6 named tributaries of GSV at, before it enters the vein, femoral vein, and these are superficial external pudendal.
Superficial.
6 together or 6 on one side?
Sir, together, sir, both.
So, first of all, never say 6, 7, 8, 9, 10. Just tell me the perspectives, okay?
Yes.
Okay, so start from the medial side and move clockwise, or start from the great saphenous and move clockwise. Tell me.
So medial accessory, this superficial.
Medial accessory. Just a minute.
Superficial.
Medial accessory.
Medial accessory branch.
Anterior lateral and posterior medial.
Yes.
What else? What else?
Sir, superficial inferior epigastric.
Right. Very good.
Superficial external pudendal. And superficial circumflex.
Look, you have the 2 pudendals. Look, you have one, the epigastric, which everyone knows.
Yes.
The funny surgery.
Yes, I didn't understand your question.
You have the 2 pudendals, the superficial and the external pudendals. Right?
Yes, deep external pudendal. Yes.
You have the anterior lateral and the posterior medial. Posterior medial is known as the vein of Giacometti. Right? And you have the circumflex iliac. So that's it.
Yes.
Sir, please. Okay. Okay.
Hello.
Yes,
sir.
sir.
Hello. So
Yes,
in this case, if we are not treating this going forward, what would the complications that may develop with this?
Patient might land into varicose ulcer.
Yes. Then.
These are usually non-healing type of ulcers, unless the cause is not.
And other complications that is there.
Give a more common complication. Have you seen that patients of varicose is coming with something in emergency?
Yeah.
Usually, pigmentation, pain.
Emergency. No, emergency complication, if anything.
In emergency complications, a patient might develop deep venous thrombosis, and because of that patient.
No.
Is DVT an emergency?
No, sir. Because of the DVT, sir, there is dislodgement of.
DVT, hardly from the varicose vein, DVT is going to their complications.
It's the other way. DVT leads to varicose rather varicose.
Yeah, in the other way. So, is there a chance of acute complications like bleeding, like that, from the varicose vein?
Yes, if the dilated vein gets injured, then there might be.
They come with bleeding.
Yeah, it's bleeding. And
So
how will you stop it?
Yes, what will you do when the patient comes to you with bleeding?
Yeah.
So we will try to ligate the vein, sir.
No, you don't try to ligate.
If you ligate the vein, what will happen? Proximally ligation.
How do you stop venous bleeding?
Venous bleeding, yeah.
Compressions.
Right.
What is
Lip elevation and compression. Right?
Yes, sir.
Lip elevation and compression.
Okay.
Can you do sclerosis?
What is the?
Sorry. So please.
What is the name of the venous bleeding called? Like artery spurts, venous did?
Ooze.
No. Wells out. Okay. So what are the other complication? What are the other complications that may be there with this CA? Can there be maybe a gangrene, venous gangrene, lower limb edema?
Yes, sir. Yes, sir.
What are other things? What do you mean by lipodermatosclerosis?
So this is a term for the chronic skin changes in these long-standing cases of varicose veins.
Yes.
In this, the limb usually takes a inverted champagne bottle appearance.
Yes, champagne bottle appearance. Yes, yes. Calcification also occurs.
Yes.
Calcification also occurs, and long-term other complication maybe even amyloidosis is also a complication for this long-term. Yes. As sir was asking about the management, yes, we are having the year of time also. Is there any role of conservative treatment in varicose vein?
Sir, in case of DVT, then we have to manage the patient conservatively, sir.
Other conservative management?
Sir, I did not understand the question. Sir.
Conservative management, is there any chance of conservative management in the deep vein thrombosis? That is your varicose veins?
Yes, sir. We can manage conservatively by giving compression stockings and
say some early asymptomatic cases.
Yes.
Asymptomatic cases, some roles of calcium dobacilates and other things are there. Yes, but here in this case, what is that was asking about this? What is the management? What may be the management? Because one side there is a recurrence, and other side is your primary cause is there.
Yes. Patient will require surgery, sir. Patient.
What are the different ways of management of varicose veins in the modern scenario?
Sir, currently we usually say that the gold standard treatment for early varicose veins is usually this radiofrequency ablation or laser treatment, sir. Intravenous laser ablation, sir.
Radiofrequency. What is called tumescent local anesthesia? That is probably what is that?
Sir, this anesthesia is used in IVLA or RF techniques, IVLA techniques. In this, under USG guidance, the anesthesia is the solution of lignocaine and lignocaine mixed with adrenaline and sodium bicarbonate is injected around the superficial vein when the catheter is has been passed through that vein. So this anesthesia gives pain control and also gives compression.
Okay. Other methods?
Sir, other methods can be said.
Other methods?
Sir, surgical methods, sir. Surgical techniques.
Other laser, role of any laser? Yes, surgical methods, no doubt. But we should try to save the great saphenous vein, because great saphenous is the longest vein in the ear. We utilize it, no? So some other procedures like what are these?
Trendelenburg procedure.
And any endovenous laser therapy is there?
Yes, sir. Endovenous
endovenous laser therapy. Yes, and what is that? That is your in local injection method.
Sir, sclerotherapy, foam sclerotherapy.
Yeah, foam sclerotherapy. These are for smaller treatment. Some flares, venous stars, and other type reticular veins, and all this. Yeah. And regarding this, what are the different types of? Have you seen a stripper? Stripping of the veins.
Yes, sir. I've done this. I've seen this.
Why not the whole of the great saphenous vein stripped out?
Sir, when we usually do the stripping till the level of the knee, sir, because below that there is increased risk of injury to the saphenous nerve also, and the patient can land into paresthesia.
Yeah. That is the reasons for which you are to give. Can short saphenous vein be stripped out?
Yes, sir. It can also be. Usually we do ligation, but we can do. But usually there is more risk of injury to the sural nerve, so we usually don't do stripping of short segments.
So if it is at all to be done, what is the which directions? And is there any directional pulling is different from great saphenous to short saphenous? Yeah, this is the method you will understand, no doubt. You will go through and these methods and all these things. Yes, sir. We are in the time constraint. Sir, moderator, sir.
I think
Hello.
we
I think
have
so.
one more case over there.
Sound problem
Normally
is there.
we permit
Yeah.
the student to also ask any doubts to get clarified. Sumit,
Yeah.
you hear
Yeah.
me?
Yes. Sir.
Okay.
Hello?
Do we have any doubts to get clarified from the senior faculty here?
Sir, I usually don't understand that part where we say that there is around 500 millisecond reversal of the flow. So can that be calculated using this duplex scan, exactly exact measurement of the, because this is
Have you ever seen a doctor?
Sir, I haven't done. Sir, I haven't done.
Okay, so you go to the radiology department there.
Yeah.
Okay, and then there are all markings which are coming up, and you can measure that in the milliseconds there, that how much the reversal of flow is there. So it's on the screen, it comes there. By that you can exactly know. And then there will be change in the, when there's a reversal of flow is there, it will change from blue to red. Okay, the type of the blood flow which is coming there, that will be changed in the color will be there. By that you can know there's a reversal of flow is there, and you can exactly measure that how much is the timing for that.
Any other additional points, sir? Ishwar sir or other faculty?
No, he has done extremely well.
Yes.
Thank
Yes.
you,
Yes.
Dr.
Done
Sumit.
well.
Thank you, sir.
Praveen sir with us? Naveen sir?
When you are describing about the treatment of the varicose veins,
Yes.
you should divide your treatment into various headings.
Yes.
Headings.
First is always there, it's the medical treatment which is there.
Yes.
Lifestyle modification which is there.
Lifestyle modifications. Yes.
Okay. Then will come the surgical treatment which will be there.
Yes.
Compression treatment is very important treatment, so compression has to be mentioned. Then the surgical treatment, and then the various types of minimal access treatment which are there.
Yes.
Okay, and the minimal access treatment can be basically divided into that whether the tumescent type or the minimal invasive, or it's the non-tumescent type. So tumescent is that where you are giving the tumescent anesthesia. So like you are doing the EVLT, or you are doing the radio frequency ablation you are doing, or you are doing the steam therapy or microwave which you are doing, they are all the tumescent variety. And there's a non-tumescent variety which are there, like you are putting the glue there.
Yes.
Or you are putting some chemical agents like the MOCA, which is there, mechanico-chemical ablation, which is there, or you are doing a sclerotherapy there.
Yes.
Okay. And then the final, which is the most recent one, is a non-invasive variety. Non-invasive is the HIFU, high frequency ultrasound. So that is also one of the treatments for now for the varicose veins. So you can divide your varicose treatment into these 5 or 6 subheadings here. Okay.
Thank you, sir. And thank you, Sumit, for joining us. Give our kind regards to Professor. So thank you for joining us today. And these clinics happen every Friday. So you are welcome to join as a guest to watch and learn from this forum. So thank you for contributing your time and energy. And we give our respects and regards to Professor and HOD of your institute. Thank you very much. Friends, we move on to the next case. We also warmly welcome Professor K.S. Rajkumar, sir. Professor K.S. Rajkumar, sir, was earlier Professor of Surgical Oncology at AIMS Rishikesh. Now, sir has taken over as head of the Department of Surgical Oncology at PhD Medical College, Coimbatore. And he kindly accepted our invitation in spite of calling him late. So, friends, the next PG resident, Dr. Arvind Somanshi, is kindly contributed by Dr. Ishwar Hosmani, sir. It's a case of a parotid tumor. Dr. Arvind, please introduce your unit chief, head of the unit, head of the department, and start your presentation. Good luck to you.
Thank you, sir. Good evening, sir. Myself, Dr. Arvind Somanshi, postgraduate in Department of Surgery in Karnataka Institute of Medical Sciences, Hubli. Under the guidance, I'm presenting a case of parotid swelling under the guidance of Dr. Ishwar Hosamani, sir, professor and principal KIMS Hubli, and my head of department, Dr. Guru Shantapai Elgachin, sir.
Arvind, welcome. I'm Rajkumar.
Thank you.
I'm driving, but I'll be able to help you out. I'm just returning from another meet, but just start. You can start. Yeah. Thank you.
Yes, sir. Thank
Thank
you
you,
so
Dr.
much.
Kanagavel, for giving me this opportunity.
Yes, sir. Sir, are you comfortable doing this, sir?
No issues.
Okay.
I'll be just reaching my home in 5 minutes.
Okay, sir.
issues.
Okay.
Thank you. Thank you.
Dr. Arvind, please start.
Yes, sir. So here is a patient, 72-year-old male, hailing from Ranebannur, Karnataka, who is a farmer by occupation, and he presented to the KIMS OPD with chief complaints of swelling in front and below left ear lobule since 30 years, which rapidly increasing size since 3 months, and complaints of pain over the swelling since 1 month. History of presenting illness. Here is a 70-year-old male patient who complains of a swelling in front of the left ear lobule since 30 years, which was initially size of 1 × 1 centimeter, which rapidly increased in size since 3 months to attain the present size and has extended below and behind the ear lobule. He also complains of pain over the swelling since 1 month, which is of dull aching type, non-radiating, with no aggravating factors, and is partially relieved by taking medication. There is no history of variation in size while chewing food. There is no history of pain while chewing food. There is no history of purulent discharge from the mouth. There is no history of any other swelling in contralateral side. There is no history of oral ulcers. There is no history of swellings or ulcers over scalp. There is no history of pain radiating to ear. There is no history of asymmetry of face. There is no history of features suggesting of facial nerve palsy, like asymmetry of face, difficulty in closing eyes, drooling of saliva from angle of mouth. There is no previous history of radiation exposure. There is no history of difficulty in swallowing. There is no history of dryness of mouth.
Arvind, I'm just going to interrupt you. So what was your idea behind asking all these negative histories? Like you have asked about many
yes, sir.
histories. Yeah. What was the idea behind? Why did you ask such questions?
So since the patient presented, yes, sir, since the patient presented with complaints of swelling in front, below, and behind the ear lobule since 30 years, which has aggravated in size since past 3 months. So so keeping a possibility of parotid swelling in mind, I wanted to rule out by asking the pain while chewing food and variation size while chewing food. I wanted to rule out if there is a salivary duct calculi, and by asking the history of any other history of any oral ulcers or swellings of scalp, I wanted to keep a differential diagnosis.
Dr. Arvind, I'll just interrupt you. Look,
yes,
you can't have a whole Dhobi list of negative history.
Yes.
Yeah.
Right? You can't just go on and on, no history, no history, no history. It has to be categorized.
Yes, sir.
You think it is a parotid, benign parotid swelling or a malignant parotid swelling, right?
Yes, sir.
So
yes.
Your negative history should be for that.
Yes, sir.
Then inflammatory, then comes other malignancies in the mouth or the drainage area.
Yeah.
Yes.
So you got to club it. You can't just say you've got contralateral side, oral ulcers or scalp, pain radiating to ear. It doesn't make sense. You get me?
Yes. Yes, sir. Yes.
So if you have features of facial palsy, you get it done in one place. If you have features of any inflammation or malignancy in the drainage area, get it in one place.
Yes.
Right?
Yes.
Just don't go around the all over the market. Right?
Yes. Yes.
Yeah. Okay. Just go on. Yeah.
Yes, sir. So the patient did not have any other history of dryness of mouth, eyes, and joint pain. and no history of loss of appetite or significant weight loss. Coming to past history.
Arvind, let me get you right.
Yes.
This dryness of mouth, you just say no features of Sjogren's or whatever you want to say.
No features suggestive of Sjogren's. Yes.
Someone asks you what are the features, then you say,
yes.
Right? You say no features of, because you're a surgeon, there's not an MBBS exam, right?
Yes.
You say no features of involvement of the facial nerve straight away, right?
Yes.
If someone asks you, you say these are the features of facial nerve involvement. Okay, go on.
Yes.
Yeah, go to your next slide.
Yeah.
Coming to past history, sir, the patient not a known case of diabetes mellitus or hypertension. There is no significant family history, and the patient has a mixed diet. He has good appetite, adequate sleep, and his bowel and bladder habits are regular. He is a known tobacco chewer since last 40 years. So, summarizing, sir, so here is a 72-year-old male presented with swelling in front and below the ear lobule since past 30 years, which has gradually increased in size since 3 months, with dull aching type of pain since 1 month, with no symptoms suggestive of facial nerve involvement.
So with this history, what is your differential diagnosis?
Sir, the first differential diagnosis, I will be like to keep a possibility of a parotid swelling, sir, a malignant parotid swelling, and the second differential diagnosis I would like to keep for a lymph node swelling.
Okay, so why do you think that this is a malignant parotid swelling? What is the history that is in favor of a malignant?
Sir, first of all, yes, sir. Sir, since the swelling is there since past 30 years, and which has aggravated rapidly in the past 3 months. Plus, he has the complaints of pain since last 1 month, sir. So this goes in favor of a malignant type of swelling.
Okay.
A rapid increase in size in a
over the last 3 months. Yeah. Okay. So now your second differential diagnosis is the lymph nodal swelling, but not a benign parotid swelling, benign parotid tumor. Why is it so? Why don't you keep a benign parotid tumor as a differential diagnosis? Why do you move to another pathology totally?
Sir, in the first place, since this is a chronic swelling and with a rapid increase in size with the pain in the swelling, the most probably it might be a malignant swelling, sir. So
that accepted. Okay.
Yes.
Coming to the second differential diagnosis.
Yes, sir. Yes.
You said it's a lymph node.
Yes.
Why not a benign parotid swelling, benign parotid tumor? So no problem. So this was a thought block, right?
Yes.
Probably you just went with the flow. So probably at this stage, the history itself, you could have just told that I'm probably looking at a parotid swelling or a parotid tumor.
Yes.
And I need to rule out a malignant change in that parotid tumor. Probably that much is enough. Okay.
Yes.
So don't straight away go and commit yourself into something. Okay. Then the whole discussion gets sidetracked.
Yes. Yes.
Okay. Okay.
Yes.
Thank you.
Arvind,
What will be the symptoms of Arvind? What will be the symptoms of facial nerve involvement? You said in the history, in the summary, no symptoms suggestive facial nerve involvement.
Yes, sir. Sir, there is the patient does not have any complaints of unable to close the eyes and any complaints of drooling of saliva, and which are suggestive of facial nerve involvement.
So, did you ask?
Present?
Did you ask this question, or the patient told about that? Have you asked?
I asked to the patient.
Okay, Arvind.
I asked to the patient.
Yes. Arvind, a patient of facial palsy presents most commonly as with what complaint?
So deviation of angle of motion.
Right. His facial, his
Facial.
appearance is involved.
Yes,
That is
and
the
the
most common,
yes,
right?
yes, sir.
Then comes
Yes.
drooling of saliva
Rolling of
and
saliva.
checking of.
Yes,
So that is the most important symptom.
yes, sir.
Complaint, isn't it?
Yes, sir. Yes.
Okay. Why is there pain in a case of parotid swelling? What are the causes of pain?
Sir, pain when there is a rapid increase in the size of swelling, that might be because of the stretching of the capsule, sir, of the parotid.
Okay, one capsular stretching is better.
Capsular stretching, or because of perineural invasion, sir.
Okay.
Yes, sir. That might be the cause of pain also, sir.
What else?
Any benign cause can be
If it is a if that is a malignant swelling, sir, so any necrosis
Arvind,
or
here
Tumor
the
necrosis.
examiner, here the examiner, he specifically asked for a benign cause. So here
Yes,
the
sir.
examiner, when the examiner is giving you a clue,
Yes, sir.
catch on to that clue.
any benign tumor still can produce pain? Any chronic benign tumors of the parotid, can they produce still pain? You asked in the history. You asked in the history certain things.
Yeah.
If silodenitis,
Chronic silodenitis.
chronic silodenitis can do pains.
Yeah.
With obstruction or without obstruction?
With obstruction, sir. With obstruction.
Where you expect obstruction?
Sir, if there is a calculi in the parotid duct,
Yeah,
sir,
we wanted the clear-cut answer.
Yeah.
If there is a duct obstruction because of the calculi, doing
Duct
the
obstruction.
chewing and other things, that can also produce pain. You have to be very
Can-
clear in your answers.
Yes.
You did ask that question in the history.
Yes, sir.
Okay, it's just yeah,
Yes.
good. Okay.
Yes.
Then when Rajkumar sir expecting the chronic benign tumor also, chronic silodenitis also could be a possibility in this case. Because there are no
Yes, sir.
symptoms suggestive of facial nerve involvement. Only pain is there. So that maybe
Pain is
goes in favor of even in a chronic parotid tumors, probably benign. It also be possible in the differential diagnosis in your case. Okay.
Yes.
Yeah, Arvind, you should not commit yourself
Yeah,
that it's benign malignant until it's clear cut. Right? You can't be
Yes.
sure it's benign malignant.
Yes, sir. Yes.
Can we go through the examination, sir?
Yeah. Yes, sir.
Go
Yeah,
for
Arvind, carry
examination.
on.
Yes. Coming to general physical examination, sir. Patient is a moderately built, nourished, conscious oriented, and examined in a well-lit room. As the vitals are stable, sir. Pulse rate is 74 beats per minute. BP is 130 over 70 millimeters of mercury. He is afebrile. There are no features suggestive of pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, and pedal edema. Karnofsky performance scale is 90, and the BMI of the patient is 21.
Yeah, Arvind, I'll just give you a suggestion. Just go back to the previous slide. So you are using Karnofsky score here.
Yes.
Yeah. It's good that you have used Karnofsky score, but be prepared for a question in Karnofsky scoring.
Yes.
They might ask you, what is that? What is 80? What is 90? What is the score? All these things. Okay. If you are not very confident of using Karnofsky score, use the ECOG score.
Yes. Yes.
That is easier, right? There is only 5 things that you need to remember.
Yes.
Okay.
Yes.
So it is the you carry whatever practice you have in your hospital, you can follow, but be prepared for that question.
Okay, sir. Yes.
When you have made the possibility of malignancy on history, which is the better score you would like to use?
If there is malignancy, ECOG score is better.
Yeah, just in proven cases of malignancy, it's better to use the ECOG score.
Yeah. Yeah. Okay, carry on. Yeah.
Yes. Coming to inspection, sir. There is a swelling of size approximately 7 into 5 centimeter in front, below, and behind the left ear lobule, which is extending inferiorly approximately 5 centimeter below the ear lobule, and about 4 centimeter anterior to it and 3 centimeter posterior to the ear lobule. The swelling appears well defined. The skin over the swelling appears normal. There are no dilated veins, scars, or sinuses. There is no other swelling noted in the neck. The facial symmetry appears normal. there is a obliteration of the retromandibular groove on the left side, and the ear lobule is lifted on the left side. On clinching the teeth.
So when you just give me a minute. Just you said facial symmetry is normal, right?
Yes.
So there is an obvious swelling in the one side of the cheek. So I don't think you should mention like that. Probably you can just say, other than this, the facial symmetry is normal. Probably.
Other than the swelling, yes.
Okay. Just use appropriate wordings. That's it. Huh? Okay. No issues.
Yes.
Yeah. Carry on.
Yes. On clenching the teeth, the swelling becomes prominent. Coming to palpations, there is no local rise of temperature. The swelling of size 7 into 5 centimeter with well-defined margins, with an irregular surface and hard in consistency, which is non-tender, which extends inferiorly till 5 centimeter below the ear lobule, 4 centimeter anterior and 3 centimeter posterior to the ear lobule. The skin over the swelling is pinchable. Swelling is mobile horizontally, but vertical mobility is restricted. There is no other swelling palpable in contralateral side of the neck. Coming to oral cavity examination, the mouth opening is adequate. There is no halitosis. Opening of the parotid duct is normal. There is no discharge found there. The left tonsil is pushed medially. By digital examination, swelling is palpable in the left lateral pharyngeal wall. The parotid duct is normal. Facial nerve examination is normal. Contralateral parotid region is normal with no swelling. There is no cervical lymphadenopathy. Coming to systemic examination, the systemic examination was normal, so there is no abnormal.
See, Arvind, here they will ask you they'll ask you to show how to examine the facial nerve palsy, right?
Yes.
All the facial nerve element palsy, how to examine, they'll ask you.
Yes.
You might be able to, you should be able to show them, demonstrate it, okay?
Yes, sir.
Okay, yeah. Carry on, yeah.
So the other systemic examination was normal. Summarizing, sir, there is a 72-year-old male with history of swelling below, behind, and in front of left ear since 30 years, which rapidly increased in size since 3 months, with dull aching pain since 1 month. On examination, the swelling is found below, behind, and in front of left ear, measuring 7 into 5 centimeter, which is hard, irregular, non-tender, with restricted upward mobility, and occupying the retromandibular groove, and there is no evidence of facial nerve involvement, and no cervical lymphadenopathy.
So yeah, now what is your differential diagnosis?
Sir, I would like to give a diagnosis of malignant parotid swelling involving both lobes, most probably
Yeah. So now, the question will be, why do you think carcinoma X pleomorphic adenoma? I think you have already told the answer. It's just reinforcement. Hello.
Yes, sir. Sir, since it's a chronic swelling of 3 months with pain in the swelling, which signifies that this is a malignant change in a chronic benign swelling cell. So the most common cause of that is which has a
Okay. So Arvind, if the history was slightly different, let us say the tumor or the swelling has been only for the past 10 years and has not increased in size. Okay.
Yes, sir. Yes.
So then what parotid tumor would you keep in, what would be your other differential diagnosis in terms of the parotid tumor itself? Elderly
case
male.
That would have been
I'm sorry?
Elderly males.
Yeah. So what
In
do you
that
think
case,
of?
that would have been a benign parotid swelling, most probably pleomorphic adenoma.
Is there anything else in an elderly male, a parotid tumor?
In an elderly male,
Any other
if there is a
common?
history of smoking, sir, diagnosis of Warthin's tumor, sir.
Yeah. Good. Okay. So Warthin's also can be a second diagnosis in an elderly male, but this patient has had it for more than 30 years. And because there is a recent increase in size and the hardness and irregularity, you are thinking more in terms of carcinoma pleomorphic adenoma involving both the lobes, right?
Yes.
Yeah. So what next? What are you going to do now?
Sir, I would like to first get a ultrasonogram of the parotid swellings, neck swellings first.
Okay. Yeah. So what do you want to see in that ultrasound? What are you going to expect?
Sir, the ultrasonogram first it shows the organ of origin, sir. Secondly, it shows the echogenicity of the swelling, sir. There it is. Yes, echogenicity of the swelling, and yes, and we can see even lymph nodes, sir. If there are any lymph nodes.
Yeah. Next.
Yes.
You are thinking the deep lobe is involved, right? You will confirm that the deep lobe is involved.
Yes, sir. Yes. But in ultrasound, deep lobe is difficult to make it.
Difficult. Yeah. Good. Okay. So if the ultrasound is clear cut, okay, you have written CT scan, MRI, and all these things. Now, when will you exactly use CT scan? When will you use a MRI? What are the indications of these two in a parotid tumor?
Yes. If you're suspecting any, we we will like to go with the MRI, sir, which gives a better delineation of the soft tissues.
Okay.
And if we want to see bony involvement or the resectability of the tumor, we would like to go with the CCT of the adenoids.
Okay.
Yes.
Okay. So surrounding structure involvement.
Yes.
Other findings,
Deep lobe involvement.
you will say that it
Deep lobe.
Yeah.
MRI will be the better option for deep lobe involvement and surrounding structure involvements.
What is the main purpose of taking MRI in a parotid tumor?
To see facial nerve involvements.
So what type of involvement will be there? Facial nerve. What will be the finding in MRI?
There will be perineural invasion of the tumors.
That is pathological. What do you see in the MRI? Or where do you look for that involvement?
Can you name where it exits? Where it exits?
Stylomastoid foramens.
So what will happen?
So there will be the widening of the foramens.
Okay. So that is one sign to say that it's a widening.
Yes.
So thickening of the, so
yes.
Which carcinoma more prone to produce nerve involvement?
Adenoid cystic carcinomas.
So what will be the manifestation? The nerve is involved. What will be the manifestation?
Sir, we can see the lower motor nerve palsy of the facial nerve branches. So if we can see the inability to close the eyes.
Okay. So that is good. That means you must think, we are expecting only the motor nerve involvement. So you don't talk about the pain and the cutaneous sensation because it is not a sensory sensation. Right?
Not a sensory. Yes.
The functional defect, motor nerve defect will be there.
Yes. Yes.
Okay. So
when you say by CT, it is
do
not.
You want
Sorry.
What is the finding in the CT to say that it is not an operable tumor?
Sir, Base of the skull is involved, like if the base of the skull is involved, like
You know, base
tympanic
of the
plates.
skull is involved. And what do you look for the base of the skull?
Tympanic plates,
Tympanic plates.
pterygoid.
Do you know any spaces?
Tympanic, which you are going to look.
Do you know any space there?
Infratemporal fossas.
Infratemporal fossa. There is pterygoid space. So we have
Pterygoid
to
space.
pterygoid space. And another indication for this is when the deep lobe you are suspecting.
Deep lobe is involved in
So that also the CT will be the good for you too.
Yes.
Yeah. Dr. Sahai has put in some messages. So CT scan indications, deep lobe involvement, facial nerve involvement, cervical lymph nodes, and in recurrent tumor, and MRI is for neurovascular involvement. Yeah.
Yes, sir. Yes.
Okay. So you have done the ultrasound scan. Do you have an ultrasound report?
Yes, sir.
Yeah. So what next with this report? So it's a 6 into 5 centimeter tumor noted in the superficial lobe with no extra parotid extension.
Yes.
Yeah. This ultrasound report is it's not adequate.
Yes, sir, it's vague, sir, and we cannot know about the deep lobe also in the ultrasound report. Sir.
Yeah.
So
Yeah.
I would like to go ahead.
You're going to get a CT scan done.
Ahead with the CT scan.
Okay. So do you have a CT
Yes.
scan? Yeah. Show us.
This is the CT scan, sir. Yes, sir.
Yeah. So choose any one picture and
can I tell
show
the
us the parotid gland. Can you zoom any one of those pictures? Choose whichever is good for you.
I'm not sorry, sir. I'm not able to zoom it. So this
no issues,
here
no
the left parotid.
Yeah.
Yes. Yes, sir.
Okay.
So the left
last
gland.
picture you're seeing.
Yes,
okay.
Sir. Around measuring around 16 to 5 centimeter as given in the report, sir. Involving the whole of the parotid is enlarged, sir, involving the deep lobe also, and it is in close relation with the internal carotid artery, sir. But it is not encasing it.
Okay. Where is the carotid? Okay.
Yes.
Okay. The larger one is the vein. The smaller one is the larger one is the internal.
Larger one is the artery. Yes.
Yeah. Smaller one is the artery. Okay.
Yes. Yes, sir.
Good. Okay. So now we have done the CT scan. What is the CT scan report?
So the lesion is measuring 16 to 5 centimeters, sir. With the necrosis in it, it is in close relation to the left internal carotid artery with no encasement, possibly deep lobe of parotid.
Okay. So in this CT scan report, are there any features that are suggestive of malignant change?
Sir, there is a necrosis between.
Okay. The tumor is heterogeneous.
Heterogeneous, right? Sir, and there is necrosis within it.
And
that
there is
only
necrosis within. Okay.
Yes,
so
yes,
there is something they have written, the encasement. What do you mean by encasement?
Surrounding, if the tumor is surrounding the internal carotid artery, so that shows
completely surrounds.
Completely surrounds.
Do you mean completely surrounds? Okay.
Yes, sir. Yes.
So okay, that is encasement.
Yes, sir.
Okay. What do you mean by abutment? Dr. Sahai is asking. Yeah.
Sir, if the tumor is in contact with the artery, then it is called abutment, sir.
Anything about the degree of contact?
Artery is abutment and the vein is encasement.
Less than 180 degrees is abutment, more than 180 degrees is encasement.
Encasement. Yes.
It is not a complete. Even if it is a 200, 220, it's a 1/3 or 2/3, it is called engagement. So not a complete engagement.
Yes, sir.
So here,
Yeah.
how do you say it is not engaged in this CT? Are you able to clearly visualize that? Or the report has given like that?
In the report.
Okay. Probably they would have seen in a big screen. Okay.
Okay. So what next? What are you going to do next?
No, the CT says it is close to the internal carotid artery.
Yes, sir.
So what do you suspect here?
Sir, the deep lobe of parotid is in close relation to the.
Have you done a bidigital palpation?
Yes, sir. I've done a bidigital palpation, sir, and there is.
We're expecting a tumor to push on the internal carotid artery, and there must be some.
Yes.
There's no bulge is there in the anterior process, no?
Apart from bulge, anything you could make out?
Sir?
Apart from bulge, would you make out anything with this CT report?
Can you see the pulsation? Where do you look for internal carotid artery pulsation?
Can you palpate internal carotid in the neck?
Look.
In the neck, internal carotid.
Internal carotid artery pulsation.
Where do you palpate internal carotid artery? Sir is asking whether you can palpate in a neck. I'm sure you can't palpate in the neck. Then where can you palpate anywhere?
Where it can be palpable then? In the neck, it is not palpable. Where else you can make out palpable? You have with this CT report.
Yes. Near the, if I do bidigital palpation, sir, behind the fascial pillar.
The bulge you can see and the pulsation you can see and feel also.
Yes.
Look into that area.
Yes.
Now it is. So what is how it comes? Is it going through the deep lobe or it is posterior to the deep lobe?
It is posterior to deep lobes.
External carotid artery?
External carotid artery is goes through the fasciavenous plane, sir. Anterior is the fasciavenous plane in between the superficial and deep.
What are the structures in the fasciavenous plane? Anterior of the external carotid artery?
No, sir. There in the fasciavenous plane, anterior lies the facial nerve, then comes the retromandibular vein, and then comes the artery, sir. It lies anterior to the deep lobes.
Okay, so good. What next? What will you do now?
FNAC report is there?
Yes, sir. FNAC report is there, sir. This shows the FNAC impression shows the adenocarcinoma of parotids.
Yeah. So your long-standing parotid swelling, when it changes to malignancy, one of the commonest findings is an adenocarcinoma, right?
Adenocarcinoma.
Yeah. Okay. Good. So now what will you do? You have a CT scan, you have an FNAC, which shows it's adenocarcinoma of the parotid. So what will you do now?
Sir, I would like to, because there is no facial nerve involvement, so I would like to go ahead with conservative parotidectomy with the facial nerve sparing.
Yeah, total
conservative parotidectomy with the sparing of the facial nerves.
Facial nerve, yeah.
Conservative, you are conserving the facial nerve. You need not say that there is no conservative parotidectomy with the sacrificing parotid.
Yes.
Yeah. So it's total conservative parotidectomy. So yeah. So now, what will be a surgical approach?
Sir, after inducing the patient under general anesthesia, I would like to take we'll take a lazy S incision or modified Pierce incision, sir. It is a the incision will start in front of the just in front of the tragus, was vertically around and goes around the ear lobule, and then it's horizontally it is extended just 2 centimeter below the angle of mandible. Sir.
Okay.
What is the difference between Blair and modified Blair?
Sir, the Blair incision, in Blair's incision, in Blair's incision, the cervical or the horizontal part of the incision we have added, sir, to make it a modified Blair's incision.
Okay. So after the incision, what will you do?
So after the incision, we'll raise the anterior flap. After in the subplatysmal plane, the parotid gland is visible, so the anterior flap will be raised.
Plane.
The flap should be thick above the.
What is the plane you are raising? It's a subplatysmal plane.
Yes, sir, subplatysmal plane.
Where is the platysma?
Subcutaneous. Yes.
Rise on the parotid or the platysma?
Sir, sorry, sir.
Where is the platysma on the cheek?
In the musculoaponeurotic
Yes.
plane. Yes.
Musculoaponeurotic is right, not the platysma. That is what
Yeah.
right.
Yes, sir.
How will you identify the greater auricular nerve?
Sir,
Is it necessary to identify the nerve?
yes, sir. Because if the facial nerve injury is there, then we need a graft so that we can take from.
Only as a stepney, not as a for the greater auricular nerve to be restored. Oh.
If you injure deliberately, would you like to deliberately cut it the auricular nerve? Or you would like to preserve many a times?
Sir, we can the anterior branch of the posterior auricular nerve can cut certainly. To proceed with the dissection.
Anterior branch you can cut, but posterior branch you try to preserve.
We have to try to preserve. So that if there is any injury to the facial nerve, we can use it as a graft.
No, even otherwise, if you are not required, even if it is not required for the facial nerve repair.
Because it preserves it gives sensation to the posterior, the angle of the mandible.
Yeah, it is very, very unpleasant sensation for the patient, the loss of sensation in that particular area. Many times patient complains of a lot of very unpleasant feeling that. So in that reason, you need to preserve for that. Okay.
While they are shaving, there's a problem, especially in the ear, they cannot feel the hot and cold temperature. That is one particular function it is doing. So how will you identify the nerve? Where do you see the nerve and what is the direction of the nerve? So it is a nerve which goes vertically upwards. You see the external auricular, we have external jugular vein, it is posterior.
External jugular vein. Yes.
That we talk more about facial nerve, but usually we will not injure it much because that be careful. But greater auricular nerve, you should be very careful to dissect it out. Like a marginal mandibular nerve, which you are giving importance, greater auricular nerve should be given much important dissection.
Yes. Yes.
In this case, you are planning for preservation of the facial nerve. So, what important steps you are supposed to take and how to identify?
So the facial nerve it can be identified through 3-4 points. Sir. First is the posterior insertion of the posterior belly of digastric. Sir. There we can find the trunk of the facial nerve, and it is found lateral to the styloid process.
How will you identify posterior belly of digastric?
So the posterior belly of as we dissect after raising the anterior flap, as we keep on dissecting, sir, the posterior belly of digastric will in front of sternocleidomastoid will be seen, sir. So we need to go till the insertion.
How will you differentiate sternocleidomastoid and posterior belly of digastric? That is why the direction of the muscle you need to know. It is vertically, it is going up. It comes transversely, it is coming. The nerve
posterior belly of digastric comes transversely, sir. And yes. And then the tragal pointer, sir, 1 centimeter below and inferior to it, you can find the facial nerve. So once we find the trunk of the facial nerve, then we have to dissect. We have to use minimal use of monopolar cautery, sir. We have to use bipolar and a blunt dissection.
You are not able to locate. What are the other options you have?
So that there is no injury to patient.
No, what are the other options? You are looking at the right appropriate space. You are not able to still locate the nerve.
Yes. So there is a stylomastoid
artery is there. All that is fine.
Yes, yes.
If you are not in the normal space, you are not able to locate.
Yes.
What are the other areas you can go and search for it?
We can go through retrograde approach, sir, if you are not able to find the.
That's not a very good approach, but okay. You said it is coming out through the stylomastoid foramen.
Yes, sir. So tympanomastoid fissure, sir. And yes, sir. So there is tragal pointer tympanomastoid fissure. There is an insertion of the posterior belly of digastrics, and there is it lies lateral to the styloid process, sir.
So when you are seeing the retrograde method, there are 5 nerves. Which nerve you will be giving much importance to preserve?
Zygomatic, sir.
Why?
Because the zygomatic nerve is the one which supplies the orbicularis, oculi and orbicularis. So if it is transected, then that can lead to exposure keratitis.
So it comes from the superior pole or the medial pole?
Sorry, sir.
Okay. How it comes out of the gland from the superior pole or from the
superior pole, sir.
So suppose you are seeing a retromandibular vein there.
Yes, sir.
So how it is formed there?
The retromandibular vein is formed from the by joining of the superficial temporal vein and maxillary vein, sir, which joins to form the retromandibular vein, and then it further divides into anterior and posterior tributaries, sir, which is joined by the anterior one is joined by the common facial vein, and the posterior one is joined by the posterior auricular vein to form a external jugular veins.
Okay, good.
Okay, so now you have identified the facial nerve, right?
Yes. Yes.
So facial nerve and its branches, and you're continuing with the parotidectomy. Okay.
Yes.
While you're doing the parotidectomy, one of the nerve branches is snaps. It is injured. What will you do?
Sir, if there is no loss of length in the nerve, then we can do a primary anastomosis, sir. If there is a loss of length, then we can do cable grafting with the help of posterior auricular nerve or sural nerves.
How will you suture that? No.
So it is called cable grafting, sir. That means the individual strands of the nerve are sutured together.
What suture material you use and what is the method you use? You use a perineural stitch or epineural stitch? Okay.
It's okay. So good. So now you have taken out the parotid.
Yes.
Without injuring the nerve.
Yes, sir.
Okay. So.
Yes, sir.
What next? The surgery is done.
Yes, sir.
Patient is happy.
Yes.
What next?
Sir, just we'll
taking out the tumor.
Yes, sir.
Yeah.
We'll wait for the
surgery is done. Patient goes home the second day. Everything is all right. Has come back a week later. Now what will you do?
Sir, we'll see the HPR report. We'll see the HPR report, sir. And if it comes as the same malignant tumor, then we have to go ahead with the adjuvant radiotherapy, sir.
Adjuvant radiotherapy. Why?
If it is a malignant.
You already made this adenocarcinoma.
Yes,
it's
sir.
already
If the HPR
HPR will confirm whatever is there, no?
Yes, sir.
What else do you want to know in that?
If there is any if the adequate margins have been achieved, sir, and
What are the points for better prognostication in the HPR report? The HPR report, which are the points favor for the better prognosis?
If there is
otherwise the worst prognosis, either way.
Yes. We'll see for if the adequate margins have been achieved, and
any pathological findings which are very important.
You were discussing while discussing the CT scan and MRI and all. You were telling something, no? What was it?
Involvement of the nerve.
If the facial.
Suppose on the table you see there is a small tissue. Okay,
yes.
Tumor is there in the nerve. You are not able to completely free the nerve. What you will do? The facial nerve
will be compromised. Yes.
Will you compromise the nerve or you will leave back the tissue?
If the nerve is, we are not able to completely free the tumor from the nerve, then needs to be compromised.
No. So two areas.
The tumor.
Facial nerve and recurrent nerve. If you have small tissues which you are not able to see for the R0 resection, even if you are going for R1 at that surrounding that region, you should save the nerve. And the adjuvant therapy which you are giving will be sufficient enough to look after that. You are not going to may not have the result. But compromising the nerve will have more damage than keeping the nerve with the micro nodules there. So both this is true for a recurrent nerve also. Recurrent nerve also you don't sacrifice just because there is a tumor, we are not able to have an R0 surrounding that region.
Yes.
So your size, T size.
This is called planned positive margin.
Yes, sir.
Okay. Okay. So what sir was telling was called planned positive margin. These are very vital structures where the damage is more when it is sacrificed. So you leave behind it and then you treat it with adjuvant treatment. Okay.
Adjuvant treatment. Yes. Yes.
Okay. So what else, sir?
You are giving adjuvant radiotherapy, and how will you follow up the case?
Sir, first we'll do follow up every 3 months for 1 year, sir, and then after that every 6 months.
What are the things you follow? What do you mean by follow up? What do you do?
Sir, because we want to check for any recurrence, sir.
How do you check?
How do you check the recurrence? Or anything else you are interested? So the radiotherapy at region, can it induce any other malignancy?
Sorry.
So the two things, one for a female, the breast should be examined properly.
Yes, sir.
And also thyroid. These two,
thyroid.
Not only the following up at the particular site of that.
Thyroid and breast.
So Arvind, so you have done a very good surgery. Yes. During the surgery, the nerves are all intact. Okay.
Yes, sir.
But
yes, sir.
In the immediate post-operative period, you see that there is some patient is having some difficulty in closing the eyelids. There is some deviation of the angle of the lip. What will you do now? You have completed the surgery. Patient is out of anesthesia. Intraoperatively, you were happy that the nerve was intact. The patient is having this symptom. What will you do?
Sir, this might be this neuropraxia, sir. So generally it resolves within 3 to 6 weeks, sir. So we'll go with the conservative management, sir. We'll wait for 3.
Okay. What?
Yes.
Yeah. Anything? What conservative management do you usually give?
Sir, we'll do physiotherapy, sir.
Okay.
The patient do physiotherapy, and then we can give steroids, sir. For we can start with patient with steroids.
To reduce the perineal swelling, you can give.
If the patient is not, yes, we can use if the patient is not able to completely close the eyes, we can use eye drops, sir.
Okay. So it's already now 6 weeks after the surgery.
Yes.
The patient's symptoms are persisting, not able to close the eyelids, one side drooping of lip is there. What will you do?
So, sir, if the
Because
still
your aim is
drooping
to
of eye,
protect the eyes, no, Arvind? Your aim is to protect the eyes. But to see that patient can have
yes,
adequate
sir.
closure.
Yes,
Can you
sir.
do any procedures?
Adequate.
That's what sir asking.
Sir, the surgical procedure which we can do is lateral tarsorrhaphy.
Yeah, see, the most important thing is the eyelid, right?
Eyelid. Yes, sir.
So what Rafi you do?
Lateral tarsorrhaphy, sir.
You see?
Using what?
You do any sling procedure or just pull it? Okay.
Right.
And so you will not try to do any, identify the nerve and do any reconstructive procedures? If there is any possibility you think of that, because you would have injured the nerve.
Yes. We can.
No improvement, that is, you should still do investigation adequately, see if there is a possibility of seeing the nerve. Then you can do a lot of other reconstructive procedure, including hypoglossal nerve. You can do a large, you can take a sural nerve and take a, from opposite facial nerve, you can take a sling here.
Yes, sir. Sural nerve. Yes.
Where do you take the sural nerve?
So sural nerve grafting is taken between the lateral malleolus and Achilles tendon, between that the sural nerve for grafts.
We must study also the anatomy of the sural nerve, the length, yes, where it comes, how it is formed. There's 2 branches, from 2 roots it comes, joints, and how much you can take. All that also important for you.
Yes. Yes.
So what is metastatic pleomorphic adenoma? So though it is a benign tumor.
Yes, sir. It can.
The reports comes that is, it can produce a metastasis.
Metastasis.
So do you think that adenocarcinoma, what are the complications specific to adenocarcinoma?
Sir, it can have lymph node metastasis, sir. Okay. So we need to go if we find the positive lymph node, then we have to go ahead with the dissection. Process.
Okay. Comparing with all the other things, pleomorphic and this adenocarcinoma has a tendency to spread to the nodes more.
Spread nodes. Sir.
So what are the complications you are expecting on this when you do the surgery after that?
Sir, after the surgery, we can have a patient can have immediate post-op complication can be a hematoma, sir. Then there might be a seroma formation, sir. There might be fistula formation. There might be Fraze syndrome.
In this case, you are going to expect a fistula formation. You are done a total conservative parotidectomy.
Yes, sir.
You are taking the globe, and then from where you are going to get the fistula?
No, sir. Here we are not going to.
It is only your case. What are the possibilities you are going to get?
Okay. So as there might be hematoma immediately, hematoma or tumor formation.
That all counts.
You can have Fraze syndrome. Sir.
What is it?
So the Fraze syndrome is cross innervation of the dermal sweat glands. Cross innervation of the dermal sweat glands by the regenerating postganglionic parasympathetic fibers. By auriculotemporal nerve.
How it will present and when it will present.
So, sir, the patient will experience while having food while chewing, the patient will experience flushing and sweating over the.
Only when they are chewing, they will get it. Is it on the chewing they are going to get, or any other thing can also produce that?
But sir, it might be by the taste or smell of the food.
Factory, all that can be.
Yes, yes, sir.
So how will you identify and how will you manage?
So once the patient comes with a complaint, we can do a starch iodine test. So the starch iodine test will confirm our Fraze syndrome. Then we can go ahead with with medical management, that is using botulinum toxin, and we can use antiperspirants. If still it persists, then we can go ahead with Jacobson's neurectomy, sir, as a surgical procedure.
Have you seen the botulinum toxin, how it is used? Okay. For maybe you are going to write for SS questions, this will be there with what is the dose, botulinum, and how much is what botulinum you are going to use. Because now more and more botulinums are tried. AWR, people are starting to use AWR. So many other reasons also, botulinum use is very much been in. Can I will, sir? You are come. Oh.
I think the student has done very well, sir.
Yes, yes. You are confident and you are answering in an appropriate way. So keep up that. This we have asked some more questions just to stimulate you to read still further. So some of the areas like that, all the nerve grafting, the newer technology, nerve suturing, the new technology. What are the sling operations which are used, and all this can be also you can study. This is worth reading the not for just passing the exam, but for your exams and scores.
Yes.
Arvind, do you have any questions to get clarified?
No, sir. No doubts. Thank you, sir.
Sir, I think you're back home now.
Yes, sir.
I would like to give closing comments, sir. Yes, sir. Would like to add something, sir?
No, sir. I think both the candidates, I was there for the previous candidate also. Both did very well. Very happy about
sir, I saw you joining much earlier.
Yes, sir. Yes. Okay. Thank you, sir. Thank you for the opportunity.
Oh.
Thank you.
Thank you, Rajkumar, sir. Thank you for maybe we may need to disturb you more often for malignancy cases whenever there is presentation. And now we are back at
yes, sir.
I think this time, unless you have commitments like this, you have a talk at around 7:30 here. So thank you for graciously accepting our request, sir. And Ishwar, sir, thank you very much.
Always happy to be part of the
permission of the faculty. Thank you, sir. Thank you. So
thank you,
wish to meet the next Friday. And wish all the best for the people who are attending the DNB exam. And a few universities have started their exams as well. Good luck to you. Good night, faculty. Thank you, residents, both Dr. Bishnoi and Arvind. Thank you for joining us.
Thank you. Thank you so much.